Health System, a nonprofit academic multi-specialty healthcare delivery system dedicated to patient care, research, and education. The Oxnard Health System includes 8 hospitals and 38 health centers located throughout southeast Louisiana. Oxnard, healthcare with peace of mind.
When Rose first started with us, she was just coming out of the hospital.
It's been a better situation. I can always depend upon her to help me. I'm home, and that makes me happy.
We're here to get her back into her routine and be able to live the life she wants to live. It's an honor to be trusted with that responsibility.
Good evening and welcome to Hello Health. I'm Tom Bagwell. Hello Health is a partnership with WLAE, the Oxnard Health System, and Humana to bring Oxnard's Hello Health weekly education and information series to television. Tonight we're going to be talking about concussions with a strong focus on sports-related concussions, although you might be surprised that most concussions aren't related to sports. 2 guests this evening, the section head of pediatric neurosurgery at Oxnard, C.J. Bui, and the director of the Oxnard Concussion Management Program, Dr. Aaron Karlin. And hang in with us here for the introductions. These guys have some experience. Dr. Bui received his undergraduate degree from the University of New Orleans. In fact, he said he took some classes in this building, the UNO Jefferson, what used to be the UNO Jefferson campus, and remained in the city to receive his medical degree from the LSU Health Science Center School of Medicine. He did his surgery internship at UCSF in San Francisco before completing his neurosurgery residency at SUNY Upstate Medical Center, that's in New York. He completed his fellowship in pediatric neurosurgery at Children's Hospital at the University of Alabama in Birmingham. Dr. Bui is board certified by the American Board of Neurological Surgery. He is currently the chief of pediatric neurosurgery and vice chairman of neurosurgery at Oxnard. By the way, he's a Ben Franklin alum. Dr. Aaron Karlin received his undergraduate degree from McAllister College in St. Paul, Minnesota. He's from Chicago originally. He received his medical degree from the Mayo Clinic Medical School in Rochester, Minnesota. Spent 8 years there in that state. He completed 2 residency programs in pediatrics and physical medicine and rehabilitation at Children's Hospital Medical Center and University Hospital in Cincinnati, Ohio. Then completed a fellowship in primary care sports medicine at the Jersey Shore University Medical Center and Rutgers University in New Jersey. Dr. Karlin is triple board certified in pediatrics, physical medicine and rehabilitation, and sports medicine. He's currently the chair of the Department of Physical Medicine and Rehabilitation at Oxnard, as well as the section head of pediatric physical medicine and rehabilitation and the director of the Oxnard Concussion Management Program. But other than that, they don't really have any experience. We're pleased to welcome to the program Drs. C.J. Bui and Aaron Karlin. We were joking that people might leave us just during the introductions, but obviously it says a lot about you and your training and your education, and thank you both for being here.
Yeah, thanks for having us,
Yeah,
Tom.
thank you very much.
Yeah, Dr. Karlin, you were on in 2009, some changes on the family side, right?
Yeah, well, got 2 kids. I got a son, Atticus, who's 7.5, and a daughter, Antoinette, who's 6 now. So neither of which have had a concussion as of yet that I'm aware of.
Very good. Son interested in playing football at some point, or?
You know, he's very much into gymnastics and baseball, and we'll see what we can do about swaying him maybe away from football a little bit.
All right. And Dr. Bui, your first time with us.
Yes.
We mentioned Ben Franklin alum, grew up on the West Bank. Do you remember what it was or who it was that first got you interested in medicine?
Well, it wasn't any one person, but I think that, the one thing that's always captured my imagination was just kind of the awe-inspiring complexity that's 3 pounds of spongy flesh can have. So
that is the brain.
Yes.
Yeah.
So I'm definitely humbled and lucky to get to work in that field.
And as much as you all, and as much as we know about the brain, there's still lots of, the honest truth, there's still lots of things about the brain we don't know, right? In this 3 pounds of flesh.
Yeah, no, I think it is really kind of the kind of next frontier for us, really. Kind of beyond space. I think just understanding neuroscience.
Yeah. Dr. Karlin, we hear more and more focus on concussions now. Let's start with a definition. What exactly is a concussion?
So a concussion is a type of traumatic brain injury. So an injury to the brain induced from a trauma. It can be from a direct hit to the head or a hit to the body, and then that force gets transmitted to the brain through the neck, injuring the brain. We've learned a lot about concussions in the past 10 or 20 years. So we treat them very differently than, say, when you and I were kids. One of the things that we know is it's a functional disturbance to a brain and not necessarily something that you're going to see on a CAT scan or an MRI. One of the analogies that I like to use about what a concussion is the old-time telephone switchboard operator. The kind that's got to put the pegs in to connect the different phone calls. And the idea is that someone came to that person's telephone switchboard with a baseball bat and hit it, and a bunch of pegs fell out. And however long it takes that telephone switchboard operator to put those pegs back in, put them in the right holes, and to have them stay is how long it takes for that individual's brain to heal from that concussion. So you can imagine then that no two concussions are going to be alike. It depends on what pegs get knocked out, how many pegs get knocked out, and how quickly that individual's operator is functioning to put those pegs back in the first place.
Before I turn to Dr. Bui, he's going to show us what a concussion looks like physiologically. How did we, and we're going to talk about how we treat concussions today, but how did we treat them 20 to 30 years ago?
Well, one of the biggest things that we looked at was one question: did you lose consciousness or not? And another question: did you have any loss of memory or not? And we've actually found out that loss of consciousness or loss of memory really has very limited bearing on how severe a concussion might be. So we figured out, we asked ourselves, well, did you have 1 minute of loss of consciousness or 20 minutes of loss of memory? And then we graded out these concussions, grade 1, grade 2, grade 3, mild, moderate, or severe. And then we told you ahead of time, oh, this is how severe your concussion is, when the reality of it is that we found out you only know how severe a concussion is based upon how long it takes for that operator to put all those symptoms, or put all those pegs back in, and for that individual's symptoms to go away.
It would not have been uncommon for a coach to say, hey, you're not out, get back in there.
Oh,
No,
yeah.
not at all.
Yeah, right.
Yeah.
We're not saying that's the right thing to do.
If you
but
didn't get knocked out, you didn't have a concussion back then.
That's right. Dr. Bush, show us what a concussion looks like.
Well, the important thing that I want to emphasize here is that a concussion is a form of traumatic brain injury. It's a mild form, but it's a brain injury nevertheless. So even if we can't see it on a regular X-ray or CAT scan, if we look at it more in-depth imaging, like one of the images we have
Let's
at
show
the bottom
people
of the
this looks
screen
like.
here, which is looking at an MRI scan that looks at blood flow and brain function. So if you look on the far left there, the concussed brain looks much more like a brain that has been injured compared to a normal brain on the right side there.
What are the colors? What do we see a lot of in the normal brain and a lot less of in the concussed brain?
So this one particular image is looking at activity and blood flow. So you're seeing a lot more normal activity and blood flow compared to the concussed brain, which is actually seeing a reduced amount of activity and a redistribution of the blood flow.
And what does the next slide show us, the side-by-side comparison?
So the next slide just emphasizes the point that some of the same mechanism that causes the concussion can cause much more severe form of traumatic injury, such as the two CAT scans seen on here, which is with bleeding between the brain and the skull and bruising deep within the brain, which all leads to increase in intracranial pressure, which is something we'll get back to a little bit later on in the show when we talk about a more catastrophic phenomena.
Very good. One thing I love about hosting this program is I'm always learning. One thing I've learned tonight, and I would have made a strong guess that most sports-related concussions are related to football, and that is the case. We're going to talk about that in a moment. But most concussions aren't sports-related, right, Dr. Karlin?
Yeah, most closed head injuries, about a quarter of closed head injuries are associated with athletics, but so that leaves about a good 3/4 that aren't. And certainly you had mentioned football. In terms of the athletic concussions, sports-related concussions. Football by far has the highest number in terms of sheer volume, sheer absolute number, and it owes itself to a couple of things. Certainly the inherent in playing football, the high number of contact or collision events that each player is introduced to, so to speak, during practice and games. But also, there are a large number, even though the numbers might be decreasing a little bit, there's still a large number of athletes that play football. For example, in high school athletics in the United States, we have 7.5 to 8 million athletes per year, and about a seventh, about 1.2 million, are playing football. So you can imagine then with those numbers, there's going to be a high likelihood of closed head injuries because of the contact collision aspects of the game, and then potentially concussions. So that's a big part of why you're seeing a lot of the football injuries.
And the sport we're seeing more and more kids playing is soccer. And you don't think of normally, you think of soccer as in fact, it's called football overseas, not here. It's called soccer. But there's a lot of action with when two players go up to head a ball. It's not just hitting the ball that could create some issues. It's two heads hitting each other.
And you bring up a good point, because a lot of people think it's the heading of a soccer ball that tends to cause a lot of the concussions, and that tends to be less the case. It's more the going up for a challenge ball and two heads contacting one another. And another part of what you're saying is it's not just football that you need to think about when you're talking about concussions. Actually, if you look at a number of other sports, and I'll list a few: women's soccer, men's soccer, lacrosse, field hockey, wrestling, and cheerleading. And if you look at those sports, the percentage of injuries within that sport that are concussions is actually higher than it is for football. So that just kind of hits home the point that you have to keep in mind that football isn't the only sport that you need to be looking for a concussion. One of the good things about concussion, though, is that for the most part, people do well. Okay? By a year, pretty much everybody, about almost 99% of folks, are symptom-free and back doing everything they want to be. Even better news, though, is by about 10 to 14 days, 80 to 90% of people who have concussions, they're going to be symptom-free, and about 80 to 85% are going to be back out on the field by a month.
Dr. Bui, take us a little further into the statistics, and then you're going to dispel a myth, too, maybe here or later in the program, about you would think the younger brain would recover quicker and be less of an issue. That's really not the case, right?
Yeah, well, I think the important number up there is that about half of the concussions go unreported for various reasons. So that means that the actual incidence of concussion is probably a lot higher than what we think. So there are a huge number of athletes out there just not getting the appropriate evaluation and treatment, which can have long-term implications. And I think that one of the common myths out there is that the younger athletes are better able to tolerate and to recover from an injury than older athletes. But actually, from the brain's perspective, it's actually not true. So the younger athletes actually take 2 to 3 times longer to recover from a concussion, and is more vulnerable to longer-term impact. That's because as the brain is growing and developing its neural networks, it's just more vulnerable to injury than a more developed brain that has the networks already in place.
And to go back to what you started with, all the telephone wires aren't before 25, 26 years old. I think the research shows when the brain is still forming, all those telephone lines aren't connected yet, right? Fully connected.
Yeah, you know, a lot of the way I think about concussions goes back to that switchboard analogy. So when you're older, say you're in your 30s or 40s, those holes in that switchboard are very well defined. And that operator knows really where they need to go. So if they get knocked out, that operator can put them back in pretty good. Now, if the switchboard gets injured, kind of like the bruising on the brain or an actual injury to the brain tissue that Dr. Bui was talking about before, then you're in trouble, because as opposed to the younger brain, where those holes aren't as well defined and maybe can help out and make up for or compensate for those injuries, you can't do that as well in the adult. But in the pediatric or the younger population, with those holes being as very nebulous and not knowing, that operator not having well defined where it goes, when those pegs get knocked out, it takes a lot longer for that operator to try to figure out where it's supposed to go, and it does take longer for that individual to get better.
Decades ago, we thought the primary symptom of a concussion was you're laid out and you're out cold. Now we know a little more than that. So what are the primary signs and symptoms of a concussion, and why is it so important to educate players, trainers, coaches?
Yeah. So again, hearkening back to that telephone switchboard analogy, I tend to look at those pegs that get knocked out falling into 4 groups of symptoms that we tend to see with concussions. First are physical signs and symptoms: headaches, nausea, vomiting, lightheadedness, dizziness, light hurting your eyes, sound hurting your head, vision changes, neck pain, balance problems, ringing in the ears. The next group of changes you're going to see are going to be cognitive or thinking changes: trouble with memory, slowed reaction time, slowed processing speed, difficulty maintaining focus, attention, concentration, trouble with word finding, feeling mentally foggy, out of it, slow. Next group of symptoms after that is going to be sleep disruption, because your brain's in charge of when you're awake and when you're asleep. So these are folks who are normally good sleepers. All of a sudden they can't fall asleep, or they're falling asleep fine, but they're waking up multiple times through the night. Or the exact opposite. They're tired all the time, excessively fatigued, low energy, taking daytime naps when they normally wouldn't. And the last group of changes, which is one that is oftentimes overlooked, is the emotional changes. So your brain's in charge of happiness, sadness, emotions in general. So these are folks who are normally pretty even keel. All of a sudden happy, sad, angry, glad, crying for no reason, excessively irritable, short fuse, snapping at people they normally wouldn't, or the exact opposite, flat, withdrawn, robotic. And so it's exceedingly important to recognize all those symptoms, because you might not have a headache if you have a concussion. It's not just a headache. It's all these other symptoms that you have to be aware of, whether you're a coach, a parent, the athlete, or the physician that's taking care of them. And so one of the big parts of the concussion management program that we work at here at Oxford, but in general, that needs to be done by physicians, is education. And so when you come and get seen through clinic, the education piece and trying to debunk some of the myths that we have in concussion management, or what we were taught in the past, is just as important as recognizing some of these symptoms.
Let's talk about some of these myths.
Well, so there's a number that are out there. First and foremost, and I think we touched upon this earlier, is you don't have to be knocked out to get a concussion. In fact, less than 20% of concussions are associated with loss of consciousness or loss of memory. We also know that if you take out male-dominated sports, so football, hockey, wrestling, MMA, that the numbers of concussions are pretty much equal between males and females. So really not a huge difference between the two there. You don't always recognize when you have symptoms the day of the event. So one of the things, like we talk about frequently, is if you think somebody had a concussion, you need to go over with that athlete or with that parent what to potentially expect over the next 24 to 72 or 96 hours, because those symptoms might not be readily apparent right then and there.
And Dr. Bui, trainers at the high school level, certainly folks with ambulance service, where you'll see at most high school football games, even at high school football practices, there's usually a trainer there. But if you go to any playground across the city, more likely that, now there may be a doctor in the stands whose son is playing, but you're not going to have trainers there all the time for every practice. So that's why this point that you all are making tonight about the younger brain being more vulnerable is important, right?
Yeah, so I think the key is education and awareness. I think that as parents, as soon as you see your kid acting not normal, complaining of headaches, just not being himself after coming back from playing, I think the first thing you do is just to notify your pediatrician, and then get evaluated. Because I think the sooner you get evaluated, the sooner you get the concussion diagnosed and picked up, and the sooner the treatment protocols can be initiated. I think that makes a big impact.
Okay, you brought some images too, especially about what a concussion could look like and force of energy, and you brought along some images to help us understand this.
Yeah, I think so. I think the first image here is just kind of highlight what we talked about earlier, which is I think that concussion in the younger age group can have a much wider implication. So even though most of the attention is on the college and professional sports, I think we need to pay a lot more attention to our youth athletes and the high school athletes. And the second misconception that's out there is that the belief that a concussion is mainly due to an unlucky head-to-head high-impact hit. But in reality, that's actually not true. That it's actually all the legal hits, the ones that has both the linear and the rotational force. That's when your head gets snapped back and turned around. That combine and causes a exponentially greater force on the brain. It's called the shearing impact, and that actually causes concussion, and not just the unlucky hits.
As you described that, I'm thinking of the linebacker or the running back coming through, and the linebacker hits him straight on, head snaps back. But I'm also thinking about a player going down, even a receiver going for a deep ball who catches it or doesn't and comes down, or the defensive back who goes straight down and hits the head. I mean, there's another example. That's not head to head, that's head to turf, but could be just as dangerous.
Yeah, and I think that so researchers are now looking at using implanted sensors in the helmets and in the mouth guards to be able to look at the type of impact, the forces, and the direction of which the players are sustaining throughout play. So
what do we see here, Doctor?
So on the left is a picture of a helmet and a mouth guard that has these special wireless sensors that can tell the person on the sidelines, how many hits the players has, what type of hits, direction, amount of force.
Anybody using these yet?
I'm sorry.
Anybody using these yet?
So several of the colleges have started using it. They're not used in the NFL yet that I know of, but they are used in a lot of the research projects. And the picture to the right there just is meant to give you some idea of the forces that we're talking about, because with a football hit, some of those hits are greater than a high-speed car crash or even a punch by a heavyweight boxer.
And then in this next image, what do we see? Again, more visuals of the brain.
So one of the surprising things that have come out of these studies with the sensors is that it's actually not just the force or the type of impact, it's actually the number of impact that seem to matter greatly. So this slide is taken from one of the studies out of Purdue, in which they tracked football players through 2 years of football play, and what they found is that when you take a sophisticated MRI scan that looks at function, that through the 2-year period there is a subset of players that are having concussion type of changes in their brain, even if they've never had a clinically relevant concussion event or a major hit. And this does correlate with neurocognitive exams they're taking, and it correlates directly with the number of hits they have, including the practice sessions.
Okay, let me jump in here for just a moment too. Talk to me about baseline. I think some high schools now are getting on a normal physical day, getting baseline of where the head is. So how does that work with the brain?
Sure.
And how important is it?
Sure. Well, it's a tool in the toolbox, is what I like to say. So what we're talking about with baseline testing, a baseline test is one that you do preemptively so that you can use it as a
in the off season.
Yeah, you can use it as a comparative tool if somebody has an injury. And there's different types of baseline tests. There's baseline balance testing that we utilize, and I think what's more commonly thought of, you're probably referring to, is baseline neurocognitive testing. Now this is, you can do it paper and pen, but what's most commonly done nowadays is a computerized neurocognitive test. And there's a lot of different programs that are out there, and without the need to name any. But those are used pre-season so that you can look at the cognitive wires. Okay, doesn't look at the balance wires, doesn't look at the physical wires, doesn't look at the emotional wires, but just looks at the cognitive wires. So just a piece of the puzzle. And then if an individual does get a concussion or is suspected for a concussion during the season, they can take that same type of test, certainly not the same content, it's changed around a bit, and then it can be compared to see if there's statistically significant decline in their neurocognitive function compared to that baseline that would suggest that those cognitive wires are out. Now, word of caution with this, it's very helpful to use as a baseline, but it is just a tool in the toolbox. If you're only utilizing that, and I will say that that happens sometimes, unfortunately, that you're only using that as your tool to say if somebody has a concussion or not, you can really be missing the boat, because they can be having emotive symptoms, they can be having sleep disruptive symptoms, and they can be completely ignored, and you can be sending somebody back too early. But it is definitely a helpful tool. It's certainly one that we utilize, but we utilize that, again, as a tool in the toolbox approach with numerous other things, whether it's balance, looking at the neurologic exam, looking at their symptom scores, and we're also even looking at some other types of things down the road.
So if I'm a high school principal or a high school athletic director and somebody's trying to sell me this, this idea of baseline testing, yes or no?
Oh, I certainly don't see a negative with it. Okay? There are definitely different programs that are out there. Some are better than others. None of them are perfect. But the idea of having a baseline test, whether you're just doing the balance testing or the neurocognitive testing, definitely is helpful in the management of that individual who may or may not have a concussion and getting them back to play. I mean, our job as concussion doctors isn't just to get them back to play as quickly as possible, but as safely as possible. And one of the other things that that neurocognitive test can do is it can kind of look underneath that scab. Somebody who's saying, oh yeah, I'm fine, but then they take that test and they're performing statistically significantly below what their norm is. I don't know that you're really that fine after all.
But again, with the cautionary note, just a piece of the puzzle.
Just a piece of the puzzle.
All right. So what should coaches and trainers be doing to ensure their players' safety? And how do you balance that with, yeah, but I really need them in this game?
That's exactly right.
And you're on the sideline for football games. You know what this is all about?
Absolutely. You know, I would tell you that it's a lot easier now than it was even just 5 and definitely 10 years ago. There's a lot more awareness through education, like programs like this, and us.
NFL changing its rules.
NFL changing its rules, and us just getting out and talking with coaches and athletes and parents, so that it's recognized a lot more, especially in the pediatric and adolescent population, as something that can, if it goes unrecognized or untreated, can have a significant detrimental effect on those kids. So I think there's a lot more buy-in nowadays than there used to be. And so if you're a physician or a parent just in the stands and you think somebody's had a concussion or you're the coach, the mantra is, when in doubt, sit them out. If you think somebody's had a concussion, you sit them out of that game. It's better to miss one game than an entire season by having something more significant or catastrophic even happening. When you do take them out of the game, you're going to want to evaluate them on the sideline. It's a more controlled situation, certainly quieter, and you're going to want to follow them over the course of the game, about every 15 to 20 minutes, to make sure that there's not any kind of decline in their neurologic function, any change in mental status, significant worsening headache, nausea, arousability, things like that. And if that's the case, if it looks like they are taking a turn for the worse, you don't need to be the hero. You know, you send them to the emergency room where they're better equipped to deal with that and evaluate somebody, because what you're concerned of, that less than 1% of the time where there is actually an intracranial process, a bleed or a bruise that's actually evolving and worsening that needs to get treated by my colleague here. And then if they stay stable on the sideline, you're going to send them home, but you need to talk to their parents. You need to go over those red flag symptoms, the things that they need to be looking for over the next 24 to 96 hours that would say, hey, if this happens, you need to go to the emergency room and have that child of yours evaluated. And if that doesn't happen, we always say, you know what, you need to get evaluated by a physician. It can be your primary care physician. That's okay. It doesn't have to be a concussion specialist initially, but then there's also the opportunity to get seen through a concussion program as well.
Share a quick story here. We've talked about it before, but a football coach who was going over to watch some younger guys who were not ready for high school yet, but part of an elementary school program, tackle football program. Coach came over and he thanked the guys for giving it his first year of the program. Thanked the guys for giving football a try, and went on to tell them, he said, you know, football's a great sport, but it's mean, it's dirty, it's nasty. You have to want to hit people and you have to want to get hit. And it's not for everybody.
Right.
And he told me later what he was really trying to do is separate the players from the non-players. But the larger lesson, which I think he also had in mind, was because he went on to say, and if football isn't for you, that's okay. Doesn't say anything about your manhood. Mm-hmm. Could be another sport that you excel in. Could be the band. It could be ROTC. It could be drama. But he was giving them permission, if they wanted to, hopefully at the end of the season rather than in midstream or mid-season, to say football isn't for, his point was that football isn't for everybody. And I think that's an expectation from parents probably. You talked about trainers and coaches and such, but parents having a real discussion with their kids about the game today.
Sure.
I remember the father of a high school athlete, very close friend, who said, let me tell you, if I had to do it all over again, I would not let my kid play football. It is he said, you would not believe the level of violence. And you're on the sideline during some of these games.
Oh, yeah.
So and that's just at a high school game.
Absolutely.
So, and I'm not trying to talk people out of football, but it
It's
does
a tough
bring
thing
me,
to do in SEC country.
Yeah, there you go.
But-
That's right.
but
And I love the game. But go ahead, Doctor.
Yeah, but I think the point is, I think parents are better informed. And I think the latest studies that have come out to show that up to 50% of parents will choose not to place their kid in full contact sports. But I think the ones that do should be properly informed of the risk, properly informed of the signs and symptoms, and like Dr. Karlin said, it's the vast majority of these, even with a concussion, to do just fine, to recover just fine. But I think the idea is the parents need to be informed, the coaches need to be informed, and the students need to be informed.
What about football at a younger age? So you said I'm going to talk to my son, maybe talk him out of playing football. And there's more and more research, and in fact, a lot of high school football coaches now will tell you, I wish the guys wouldn't start playing. There's a case to be made for not playing full-level contact football till you get to the high school age. And now the more I listen to you both talk about the brain not being fully formed and the higher risk of danger at that early age. Quick thoughts from both of you.
So it's a double-edged sword. First and foremost, I was being a little bit flippant to say that I'm going to sway my son away from football. Right. If he wants to play football, he's going to play football.
We'll talk about it.
We'll talk to my wife about that.
That's right.
But it's a definite, and there's a lot of positives about playing a team sport, especially football. I mean, the camaraderie between the team, learning the team approach, and the bond between those players. Being out there on the field, laying it off. There's a lot to be said about that. One thing about certainly decreasing the number of exposures is key. So we say at the middle school or the junior high level, even though the kids are smaller, there's still exposures. And so there's the thought, well, maybe they should just play flag football until they get to the high school level. And I think there's a lot of positive value for that. But then at the same time, the double-edged sword is they're not going to learn to tackle as well. And that's one of the biggest issues now in high school football is you don't have these kids, the heads-up program, right? Head up, tackle them, straight on. They don't teach tackling as much as they used to. They spend less time tackling. And so what you tend to see is a lot of these guys shooting themselves like missiles at one another, head down, and using all the padding that they have to kind of feel like they're protected, when the reality of it is that padding isn't going to necessarily protect them from a concussion. So, I think there's definitely some merit to not having the kids playing the contact collision sports, especially football at a younger age. I don't know if I have a well-ingrained decision on that yet because of the double-edged sword nature of it. And again, it's not just football. There's so many other sports where you can get concussions in as well.
And how many times do you see a really form-perfect tackle on SportsCenter? You don't.
No, you really don't. Those are the ones that make it onto SportsCenter, the ones that are basically resulting in someone getting laid out, which is the exact opposite of what we're espousing.
I think they got rid of the jacked up segment once the NFL changed its policy. And we'll talk about the NFL rule changes in just a moment. But Dr. Karlin, at what point should someone call a concussion specialist?
I think that's a great question. I certainly think primary care physicians are well equipped through their education to manage concussions in the acute phase, meaning in the first week or so. I think at the same time, I wouldn't fault a primary care physician who feels uncomfortable with a concussion, sending them straight away to a concussion management specialist. But certainly after 7 to 10 days of continued symptoms, I think that's the time to go to the bullpen, so to speak, and send them to the concussion specialist. Not for one reason more than any other. I think we're going to spend a lot of time with the education piece, explaining what a concussion is, how to manage it initially, and then if the symptoms do persist beyond that 3 to 4 weeks, that 80 to 85% of folks are actually completely resolved and back doing everything by, we're going to be able to kind of address those persisting symptoms in a specific fashion.
So how are we treating today?
Yeah, so, well, first and foremost, it's relative rest. Okay, relative activity restrictions, emphasizing both physical and cognitive rest, but the word relative is very important. We're not talking about putting a child in a sensory deprivation room, turning the blinds down, turning off all sight and sound. That actually works against you. Actually being a couch potato works against you. We want them out doing regular activities of daily living. We want them going for a 30-minute walk at least once or twice a day. We do want to limit the cognitive stressors, the TV, the computer, the video games, the texting, telephone, iPhone, all that kind of stuff. We usually say 30 minutes on, 30 minutes off, but there's nothing magical about that. You watch television for 35 minutes, your head's not going to explode or anything. But you need to meet 4 simple criteria that we're looking for before we're going to start you back to return to play. And while these are our rules, these are also the international rules on getting back from a concussion. So first and foremost, you need to be symptom-free, or at least back to what your baseline was prior to when you had your concussion. Next, we need to have a normal neurologic exam. We don't want to have any abnormalities on there that tell us that there's some lingering symptom from a neurologic standpoint. You need to have normal balance testing, which is a big part of the exam that we do. And then finally, we'd like to see normal neurocognitive testing, whether that's in comparison to a baseline, which we talked about before, or comparing you to age-adjusted norms. Then and only then, when you've met those criteria, is it really safe to start that graduated return to play schedule. And that's really no different than what you would do for a sprained ankle. There's steps to the process of increasing stress that's put on that brain or shaking that switchboard a little bit harder, making sure that none of those pegs pop back out and you start having symptoms again. It starts with light aerobic activity, progresses to full aerobic conditioning with the team and non-contact position drills. After that, you move to full non-contact practice and resistance strength training, excuse me, because that's actually harder on your brain than running. And then full contact under supervision, and then you move on to full gameplay thereafter. Each one of those steps needs to take a minimum of 24 hours, but it can be longer. If it's a younger kid, like CJ was mentioning earlier, we need to be more conservative because that brain's younger. So it's very much an individualized approach.
If you watch the World Series, you know, Matt Harvey argued with his manager, wanted to come out, had to pitch the 9th inning. This is my game, I've got to be in there. What role does the athlete play in deciding when to come back in?
Very little. And I mean that flippantly. What the athlete's going to be doing, we have to rely on that athlete to tell us what symptoms they're having. But really, that athlete wants to come back. I mean, if you ask them all, 100% of the time, they're going to want to be back there with their team. So you have to kind of remove that responsibility on them because they want to please their coach, they want to please their parents, they want to please their peers, and they want to succeed. So we need to give them the assurances that, you know, this isn't on you, this is on us to make sure that we're going to get you better, and we need to be looking out for them and looking for those 4 criteria and then moving them through that return to play as quickly as possible but as safely as possible. I like to say when I kick them out of the office, I don't want to ever see them again. It might be good for business, but it's not good for their brains.
All right. We invite you to call us now with your questions about concussions, and if you have a story you want to share with us, feel free to do so. Our phone number is 504-866-3200. That's 866-3200. Or you can send us questions by email at hhquestions@wlae.com. The time to call is right now. Dr. Karlin and then Dr. Bui. So let's talk about the risks associated with getting back on the field too soon after suffering a concussion.
Sure. So the 4 main reasons why we don't want you to get back to athletics or any activities that have the risk for contact or collision before you've met those criteria we talked about. Number 1, well, just like when you have a sprained ankle, if you go back to sports too soon before it's healed, you're at an increased risk of re-injuring your ankle. So if you have a concussion and you go back too soon, you're at an increased risk of getting another concussion. It tends to take less of an impact to do it. The symptoms tend to be more severe and they tend to last long. The symptoms tend to last longer, months instead of weeks, and that could be that individual season. So we don't want that. We also know people that get concussions, even if their symptoms are gone in 24 hours, what we used to call getting your bell rung, getting dinged. We don't use that terminology anymore because we found out that that brain, even though those symptoms feel as though they've resolved, that brain is actually abnormal in terms of its neurometabolism. The way that it makes decisions and sends signals to the body is actually off for about a week. Just like that scab that you press on and it feels fine, but then you peel it and it starts bleeding. Your skin takes a certain number of days to heal. Well, your brain's just like that, and it's about 7 days. So we don't want them going back too soon because that's like picking at that scab, and that can delay recovery. That's number 2. And the main reason why I care mostly about that is because if you continue to do that and you remain symptomatic for more than a month, then you're in what's called post-concussion syndrome territory. And for every week and for every month that you continue to have symptoms beyond that period of time, it becomes harder and harder for that operator to put all those pegs back in. And the risk becomes higher and higher that whatever symptoms you're having can become permanent. permanent headaches, academic decline, sleep disruption, emotional changes. Not that they will, but the longer you have it, the harder it is. And then the scariest risk, especially in the 21 and under population, a still growing, developing, immature brain, is something called second impact syndrome that Dr. Bui here knows quite a bit about.
Yeah. We're happy in your office. We don't want to be with Dr. Bui in the operating room, right?
No, yeah. So I think, like Dr. Karlin said, the vast majority of concussions are mild, but the one major life-threatening potential for a repeated concussion, especially if the brain has not had enough time to recover, is a phenomenon called the second impact syndrome. Even though it's rare, it's almost universally a very, very poor outcome. And the mechanism is not well understood, but it's essentially the concussed brain's inability to auto-regulate a lot of the pathways and the blood flow to the brain once it's already compromised, leading to a very nasty cascade, which leads to very rapid brain swelling, which can rapidly lead to death. And of the few cases that actually make it to me in time, I actually have to do a very aggressive operation to remove the skull from both sides.
To relieve the pressure.
Relieve the pressure. And that may be a life-saving procedure, but almost universally, the long-term neurologic and cognitive outcomes are very poor. So I hope that puts into perspective how important it is to recognize concussion early, get involved in the proper treatment protocols, and not to rush back into play.
Certainly you all have made that case strongly tonight. Again, we look forward to your questions coming next. 504-866-3200, 504-866-3200, or questions by email at hhquestions@wlae.com. We'll take a break and come back with your questions in just a moment. This is Hello Health on WLAE.
I need help finding a doctor.
PACE.
I needed help with my medication.
PACE.
I needed help getting around.
The Shirley Landry Benson PACE Center is a place that helps seniors remain in their homes, providing the care they need. If you or a family member are over 55 years old, you may be eligible for benefits offered by PACE. For more information, contact us at 504-835-0006. PACE, caring for those who cared for us.
They say that when you're facing extreme danger, your life flashes before you. If you think that's sad, consider facing it before you even have enough life to flash before your eyes. Deaths and injuries can be prevented by using the right car seat. Visit safercar.gov/the-right-seat to know what is appropriate for each age and size.
And welcome back to Hello Health. I'm Tom Bagwell. Good to have you with us tonight. Two guests tonight. We're talking about concussions with Dr. C.J. Bui and Dr. Aaron Karlin. Let's get to your questions right now. Thank you for holding line one. Kelly calling us from Kenner. Kelly, you're on Hello Health.
Hello, how you doing?
Fine. Go right ahead with your question.
Well, I have a question. Well, my son, he just went through, he has a broken collarbone, and he has suffered from a concussion, and this concussion considered him having stuttering, memory, and balance. And he's in therapy for all of those right now, and he's still going through the symptoms and everything. And I was wondering, how long do you think he recovered from stuff like that?
How long ago did it happen?
It happened on 9/28.
Okay.
Oh, that's a great question, Kelly. You know, what I would say is it differs for each individual. I mean, you're already a month out, so you're kind of in that post-concussion syndrome territory. You know, anybody who's having symptoms beyond 2 weeks, there are certain symptoms that we start to treat with medications. Headaches after 2 weeks of continuing headaches, we tend to treat with certain medications. Cognitive trouble, difficulty with things in school, memory, we start treating around 3 or 4 weeks. The stuttering, a lot of times we're going to get that kid involved with a speech therapist if that's persisting past a month, and it sounds like it is in your son's case. I think your son's injury unfortunately illustrates a excellent example of someone who would benefit from getting seen by a concussion management specialist. You know, the one thing that I wish I could tell you is how long it's going to last. It's different for everybody, and it kind of depends on what's been done to this point and what's going to be done for him kind of going forward.
Because he also had like blackouts and stuff. He had to go through all of that, and like tomorrow he go see the concussion doctor for a checkup tomorrow. He just came from therapy for his balance today.
Well, it sounds like you're plugged into the right person. If you're seeing a concussion doc, that's a good first step. And if he's being evaluated for his balance difficulties still, it sounds like that's another good piece of the puzzle that's being evaluated.
Kelly, while we have you on the line, was this a football-related injury?
Yes, sir. He plays football.
Okay.
Well, he's out for right now. They have him out for the remainder of the year, for a whole year, actually. No activities, no sports. They don't much want him getting a physical fight right now. Because they say his was like unusual concussion. So by him stuttering, and then they say it was unusual, they haven't saw that it's like rare.
Yeah, you know, oftentimes it's again an individualized approach. It's real easy to get swayed by certain symptoms that are atypical and consider that a more severe concussion. That isn't necessarily the case, but again, without having, you know, met your son and evaluated him, it's hard to say if he would truly need to be held out for an entire year from contact collision sports. Usually something like that we reserve for somebody who's had multiple concussions or has unfortunately had to pay a visit to Dr. Bui because they had a bleed or a bruise on their brain.
All right. Kelly, thank you so much, and best of luck to your son. Let's go to line 2. Michael calling us from Metairie this evening. Michael, welcome. You're on Hello Health with our doctors.
Well, thank you very much. I appreciate y'all talking about this today because it's been very informative. I'm actually going to be on the other spectrum. My 6-year-old daughter today fell at school and we went to a primary care physician, and she actually had a mild concussion, and she was cleared to go home and rest. However, my question is, when I was growing up, they told you not to fall asleep after a concussion. Is that still true today, and what were the positives and negatives of that, of not falling asleep?
Well, Michael, just before the doctors jump in, I want to thank you for calling. And as we mentioned at the beginning of the program, in case you're joining us late, most concussions have nothing to do with sports-related injuries, although that's our primary focus tonight, 75% of them. So we're really glad you called to tell that story.
Sure.
No, I think, you know, now I wouldn't say that, you know, the falling to sleep is a major concern. I think the issue is just, you know, as long as the parents are aware of the signs and symptoms, I think before we had a better understanding of it, I think, you know, the idea was just to not let the kid fall asleep so that the parents wouldn't miss something. But I think, you know, now that we have a much better understanding of it, and now that, you know, for mild concussion, things like that, I think it's absolutely fine.
But certainly was the advice. We were all nodding our head when Michael was telling us that story.
Sure, yeah. You know, so Michael, one of the things that I'd say is the reason why we used to get told that is the fear of that person decompensating through the night and stopping breathing because of extension of a brain bleed or something like that. And they said, okay, you're going to need to wake them up every 2 hours and check in on their mental status and see if they're still able to answer questions. Well, for a lot of teenagers or even a 6-year-old, if you wake them up every hour or 2 hours through the middle of the night, they're going to be pretty belligerent. They're not going to be that happy kiddo that you normally see. So that doesn't tend to hold weight. And the other thing is, well, say you wake them up every 2 hours. Well, you wake them up, the kiddo's doing fine, but then 10 minutes later was that period of time in which they would have that decompensating episode because the pressure in their head got so great. Well, you would have missed it. So what we generally recommend is, you know, if you're awfully concerned about it, you can, you know, keep them in your bed that night so that they're next to you, but you don't need to be waking them up every hour or 2 hours, things like that. If you're so concerned about changes in their behavior, changes in their mental status or things like that when before bedtime, that's the kind of person that should be evaluated in the emergency room.
Michael, all good?
Yes, sir. Thank you very much. I appreciate your time.
Thank you for
bet.
your call tonight. Our phone number, by the way, is 504-866-3200, 504-866-3200. We do have some phone lines open. Let's go to line 3. Patty calling us from Metairie this evening. Patty, you're on with Dr. Bui and Dr. Karlin.
Hi, thank you very much. I have a 14-year-old son who likes to play sports, particularly football, and after watching the show tonight, it does make me have some serious concerns about head injuries and sports and that sort of thing, and then the effect on them into their adult life as we see these professional athletes are all having some serious issues with the remnants of head injuries. What do you recommend? Is there a safer way for these children to play football? Are there some special helmets? What do you recommend?
For the record, by the way, both of our guests tonight played football in high school, and then Dr. Karlin went on to play baseball in college. But go right ahead, jump in.
You know, it's a great question, and it's a difficult one to answer because we don't want our kids to be couch potatoes. We want them to be playing sports. Or at least being active, whether it's sports or drama or just getting out and exercising. You can get a concussion, you can get a head injury. Again, we talked about this before, doing numerous activities that are not associated with athletics. So just playing athletics doesn't mean that your child's going to get a concussion. And I don't want this program to discourage parents out there to having their kids participating in athletics, even contact collision athletics. You just need to be educated. You need to be aware. You need to know what the signs and symptoms of a concussion are, so that if that does happen to your child, granted the chances are probably not, because it's more kids are playing sports and not getting concussions, but if it does happen, to how to treat it and take care of it better. You did ask one question about helmets. And that's a tough a question that a lot of money and research has gone into, and Dr. Bui talked about that in terms of the sensors. An analogy that I use frequently is the raw egg. If you take a raw egg and you shake it hard enough, you can break the yolk inside. And unfortunately, there has not been a helmet to date that's been made that will fully protect somebody, whether it's a football helmet, or a lot of the questions that we get are about those soccer helmets as well, or not helmets, I should say, headgear, that protects or reduces the risk of concussion. And unfortunately, there has not been any research to show that that happens. It can reduce impacts, reducing the risk of skull fracture, but not the risk of concussion. So overall, I would encourage everybody to have their children involved with athletics in some form. I think it's great exercise, and it's good for team building and maturity and development. You just need to be educated about what the risks potentially are in doing so.
Dr. Bui would not let his son play football, but that's only because he doesn't have a son, right? Only a 5-month-old daughter. But what if you had a son who wanted to play football?
Well, I think that the general trend for younger athletes is, I think, going to lie in how the coaches and the schools institutions are going to minimize the full contact, the number of full contact hits throughout. So I think currently, up to 19 states have actually have passed laws that limit high school and the youth leagues to just 2 days of practice for full contact, no more than an hour and a half of full contact, and no full contact during the off season. I know a lot of coaches are groaning out there about that, but actually some of the very, very successful football programs, like SMU, don't have full contact in the off season, and they have very limited full contact for practices. So I think as we move more towards limiting, and then later on maybe being able to track the number of hits. In baseball we have the pitch count for the pitchers. We're looking to protect the arms, but I think that later on, as technology gets a little bit more affordable, I would envision you being able to track how many hits throughout the year your kid's hitting, and then being able to make a decision about safety and things like that.
I think this is the first year where the NFL instituted its new rules about contact at spring training, spring practice. Before, And I know I'm a football fan. I'm assuming both of you guys are who played. I certainly don't notice a discernible difference in the contact level or the quality of the game at the NFL level. Do you?
No, certainly not. And you know, that was primarily intended to decrease the one, like Dr. Bui was saying.
Frequency.
Yep, the frequency, the number of exposures. But you know, in football in general, there's only about 5% of all total injuries in football are concussion related. So you're looking at 95. We're talking about knees, ankles. Kyrie Robinson yesterday with a tibia fracture. Right. So there's a lot of other non-concussive injuries in the NFL that those contact practices are the limiting of contact practices trying to address. But certainly the level of play has not seemed to take a dip in any way.
We got a couple of emails I want to read for you here, so feel free to chime in. Here's an email. I've had my bell rung twice when I fell and hit my head. Felt better very soon, but could I have had a concussion and could I have consequences as a result of these falls? This is from Doris. Not knowing the particular circumstances would be tough. Right?
Yeah, it's certainly, you know, it's hard to know what you meant by getting your bell rung. If getting your bell rung was you had a little bit of a headache for a little bit, well, maybe not. But if you had headache, dizziness, some nausea, some mental status changes, yeah, you probably had a concussion. Whether that had long-term consequences or not, that would be definitely difficult to kind of discern without evaluating you and going into more depth in terms of looking at cognitive function exams.
Doctor, the biggest thing is whether you're having symptoms now or actually having symptoms after these events. And so if you're far enough out from this event and are symptom-free and not having any headaches or things like that, then I think you can rest assured that whether you had a mild concussion or not, it's currently no longer an issue.
Okay, we have time for one more email, it looks like. Is there a relationship between concussions and neurological diseases such as ALS, Parkinson's, and Alzheimer's? And that's a terrific question to end with.
Yeah, so, you know, currently the NFL is spending a lot of money and actually a lot of researchers, and, you know, just the preliminary data is that there does seem to be some connection with repeated head injuries and a particular protein called they call it tau protein, which has been linked with Alzheimer's, and so there's very early data to suggest a link, but at this point we don't have any anything concrete yet, and so you know.
And Dr. Karlin, last word for you.
Yeah, so I would say in terms of ALS, I don't know that we have anything discernible. I think that gets a lot of publicity here.
Because of Steve Gleason.
Because of Steve Gleason. Parkinson's, there's the idea of pugilistic Parkinson's, Muhammad Ali, and that. But from the Alzheimer's standpoint, this entity known as chronic traumatic encephalopathy, which is what CJ here was alluding to, is you can see changes in the brain akin to the kind of changes you would see in a 70, 80-year-old individual's brain that has Alzheimer's in the 40 and 50-year-old ex-NFL, NHL athlete's brain. And it presents with changes in emotionality, with lability, dementia, et cetera. And
relationships.
Absolutely. A lot of high-profile athletes have had some pretty significant events, Junior Seau, for example, and others. Unfortunately, this can only be diagnosed with biopsy of the brain after the person's passed away.
All right. I want to thank both of our guests. It's been a fascinating hour. You brought everything as advertised with the introductions. I'm glad we went through them, and I'm very glad you were both here. Thank you so much.
Thanks a lot,
Thank you very much for your time.
Yeah, for being here and for your work at Ochsner. Well, that's our program for tonight. To make an appointment with any Ochsner physician, including tonight's guest, or to register for any of Ochsner's Hello Health seminars, you can call Ochsner at 504-842-5669. It's a number set up just for viewers of this program. As a reminder, you can rewatch tonight's presentation or any of our Hello Health programs on our website at WLAE.com or on Ochsner's website at Ochsner.org. Our thanks again to tonight's guests. Thanks to Humana and Ochsner for making our program possible. And our final thanks is to you. Thanks for watching Hello Health on WLAE.
Hello Health on LAE is presented by the Ochsner Health System, a nonprofit academic multi-specialty healthcare delivery system dedicated to patient care, research, and education. The Oxnard Health System includes 8 hospitals and 38 health centers located throughout southeast Louisiana. Oxnard, healthcare with peace of mind.
When Rose first started with us, she was just coming out of the hospital.
It's been a better situation. I can always depend upon her to help me. I'm home, and that makes me happy.
We're here to get her back into her routine and be able to live the life she wants to live. It's an honor to be trusted with that responsibility.